Hey friends, you're studying really well these days. Keep going. Make your own short notes and keep building them step by step. That's how real progress happens. Now, in part 5 of BNF Chapter 1, we're going to explore two important topics: Gastro-oesophageal reflux disease, GORD, and Helicobacter pylori infection. So grab your notes. Let's make your understanding super strong today. What is GORD? GORD is a chronic condition where stomach contents, especially acid, bile, and pepsin, flow backward into the esophagus. This reflux causes heartburn and acid regurgitation, which are the main symptoms. Sometimes, the acid can even reach the throat or airways and cause chest pain, hoarseness, coughing, wheezing, asthma, or even dental erosion. Types of GORD. There are two main forms. 1, non-erosive GORD. Symptoms are present, but endoscopy looks normal. 2, erosive oesophagitis. Inflammation and erosions are seen during endoscopy. Risk factors. Certain things can increase the risk of GORD, including fatty or trigger foods, pregnancy, family history, hiatus hernia, straining or coughing that raises stomach pressure, stress and anxiety, obesity, smoking and alcohol use. Some medications like NSAIDs, beta blockers, calcium channel blockers, steroids, bisphosphonates, and tricyclic antidepressants. Possible complications. If untreated, GORD can lead to esophagitis inflammation, ulceration or bleeding, strictures, narrowing, anemia from chronic blood loss, aspiration pneumonia, and Barrett's esophagus, a precancerous change in the lining. Aims of treatment. The goal is to relieve symptoms, promote healing, and prevent recurrence and complications. Non-drug lifestyle management. Start with lifestyle measures. Eat healthy and lose weight if overweight. Avoid trigger and fatty foods. Eat smaller meals and finish dinner at least 3 to 4 hours before bed. Raise the head of the bed if nighttime reflux is an issue. Quit smoking and reduce alcohol. Manage stress and anxiety because they can make symptoms worse. Remember, urgent endoscopy is needed if a patient has difficulty swallowing, GI bleeding, unexplained weight loss, or is over 55 with persistent reflux or upper abdominal pain. Endoscopy may also be used to check for Barrett's esophagus. Drug treatment step 1. Review medications. Stop or reduce drugs that can worsen reflux, such as alpha blockers, anticholinergics, benzodiazepines, beta blockers, bisphosphonates, calcium channel blockers, corticosteroids, NSAIDs, nitrates, theophylline, or tricyclic antidepressants. Long-term continuous antacid use is not recommended. Step 2. Initial treatment. For confirmed GORD, start a proton pump inhibitor, PPI, such as omeprazole, lansoprazole, pantoprazole, or esomeprazole, usually given for 4 to 8 weeks. If there's no response, try a histamine 2 receptor antagonist H2 blocker, such as famotidine or ranitidine. Note, ranitidine is now rarely used. For severe oesophagitis, continue a PPI for 8 weeks and adjust for patient factors and drug interactions. Follow-up management. If symptoms persist, check for alarm symptoms or other causes. You can repeat the PPI course for 1 month or double the dose for 1 month. Add a H2 blocker at bedtime if symptoms appear at night. Recheck lifestyle changes and medicine adherence. If symptoms come back later, continue PPI at the lowest effective dose or take it as needed. If one PPI doesn't work, switch to another based on tolerance and interactions. Patients with strictures or severe oesophagitis often need long-term PPI therapy. GORD in pregnancy, heartburn, and reflux are very common in pregnancy. Start with lifestyle advice and dietary changes. If symptoms continue, try an antacid or alginate like Gaviscon. If still not controlled, omeprazole or ranitidine, unlicensed use, can be considered. Awesome work so far, friends. You've done great understanding GORD. Now, let's move on to the next important part that's closely linked to it: Helicobacter pylori infection, or simply H. pylori. Description of condition. H. pylori infection is one of the most common causes of peptic ulcer disease. It's found in about 95% of duodenal ulcers and 70 to 80% of gastric ulcers. When a patient uses NSAIDs and also has H. pylori infection, the risk of ulceration and bleeding increases even more. That's why identifying and treating H. pylori is so important. It's also linked with acute and chronic gastritis, gastric cancer, and malt lymphoma, a type of stomach-related lymphoma. If you don't know the word lymphoma, search for it now and remember it now. Okay, aims of treatment. The goal of treatment is simple and powerful. Eradicate H. pylori, reduce the risk of ulcers, bleeding, and gastric cancer, and prevent recurrence of gastritis or peptic ulcers. Testing for H. pylori. Before starting treatment, it's essential to confirm the presence of H. pylori. This is called the test and treat strategy. Testing is recommended for patients with uncomplicated dyspepsia who don't respond to lifestyle changes or a 1-month PPI course, patients at high risk of infection, anyone with a history of ulcers or GI bleeding, before starting long-term NSAIDs in patients with previous ulcers, and those with unexplained iron deficiency anemia after excluding other causes. Common diagnostic tests include urea breath test, MOHC, stool antigen test, SAT, or validated serology, only if locally approved. Important, do not do the urea breath test or SAT within 2 weeks of PPI therapy or 4 weeks after antibiotics, as these can cause false negatives. Office-based serology tests are not recommended because their accuracy is low. Retesting for H. pylori. In most cases, retesting after treatment isn't needed for simple dyspepsia, but Public Health England, PHE, recommends retesting when compliance with treatment was poor, local resistance rates are high, symptoms persist, or the first test was done too soon after PPI or antibiotics, the patient had a peptic ulcer, malt lymphoma, or early gastric cancer, the patient is taking aspirin without a PPI, or severe or recurring symptoms continue despite treatment. Retesting should be done at least 4 weeks, ideally 8 weeks, after therapy. If acid suppression is still needed, use H2 blockers instead of PPIs before retesting. The urea breath test is preferred for retesting. Drug treatment. Treatment usually involves triple therapy. That's a PPI plus 2 antibiotics for 7 days. PPIs include omeprazole, lansoprazole, pantoprazole, esomeprazole, or ribeprazole. The antibiotic choices depend on whether the patient has a penicillin allergy or not. If no penicillin allergy, first line for 7 days, PPI plus amoxicillins, clarithromycin, or metronidazole. If no improvement after first line, second line for 7 days, PPI plus amoxicillin plus the alternative antibiotic not used before. If symptoms continue after using both clarithromycin and metronidazole, alternative second line for 7 PPI plus amoxicillin plus tetracycline, or levofloxacin if tetracycline can't be used. For resistant cases, under specialist advice, third line for 10 days, PPI plus bismuth subsalicylate plus 2 unused antibiotics such as rifabutin or furazolidone. If penicillin allergy, first line 7 days, PPI plus clarithromycin's metronidazoles. If the patient already had clarithromycin before, alternative first line 7 days, PPI bismuth subsalicylate plus tronidazole tetracycline. If that fails, second line 7 days, PPI plus metronidazole plus levofloxacin. And if the patient has already taken a fluoroquinolone, alternative second lines, PPI bismuth subsalicylate plus metronidazole tetracycline. Finally, third line, 10 days under specialist guidance, PPI plus bismuth, either rifabutin or furazolidone. Important reminders. Always check antibiotic history. Every previous use increases the risk of resistance. If diarrhea develops during treatment, consider Clostridioides difficile infection and review therapy. Emphasize adherence. Completing the full course is key to success. For complicated or resistant cases, refer to a specialist or contact the Helicobacter Reference Laboratory, UK guidance, for advice. All right, friends, this is our Today Note, and honestly, I'm so proud of you for learning step by step. Take a minute to write your quick notes, keep your focus strong, and stay confident. And hey, don't forget to like, share, and subscribe. It really helps our study family grow. See you in the next video.